Good morning, everyone. My name is Lea Fayad, and today I'm going to be presenting compression anastomosis for gastro-jejunal anastomosis creation. I have no financial disclosures or conflict of interest to report. The general principles of anastomosis creation dictate that an optimal anastomosis requires a good blood supply and optimized tissue apposition without any interposing tissue. This is in order to aim for low bleeding, leak, and stricture rates. Nowadays, most anastomoses are created surgically using suturing and stapling techniques, but endoscopic approaches have been developed as well more recently. The gastro-jejunal anastomosis in particular has been widely used in the management of obstruction, particularly malignant obstruction, but also in the management of obesity and metabolic disorders. Magnetic compression anastomoses have been used for a long time. In fact, the first one was performed by Bora et al. In 1978. Since then, it's been applied for a variety of vascular, genitourinary, and GI applications, including in the biliary tree. The idea behind it is that magnetic force between two magnets will lead to tissue necrosis of interposing tissue over several days, thus creating a fistulous tract. The magnets are released and fecally excreted when this is done within the GI tract, thereby having no retention of foreign material. In 1995, Cope et al. Performed the first study using magnetic compression anastomosis to create a gastrojejunostomy. They used rare earth magnets and performed a porcine study where they implanted magnets by different techniques, perorally, percutaneously, and surgically, in 9 pigs. They followed them at 7 to 13 days, and they found that there was one partially patent anastomosis, but the rest were completely patent. One of these anastomoses did become occluded at 30 days. However, overall, there was no leakage, infection, or bleeding. This study was an excellent proof of this concept of using magnets in the creation of gastrojejunostomies. 10 years later, in 2005, Chapita et al. Also created a gastroenteric anastomosis using magnets. However, this time, the study was performed in humans, and it was performed endoscopically. 15 patients with malignant gastric outlet obstruction were included. The magnets were deployed, one in the distal duodenum using guide wire and fluoroscopic guidance, and the second in the stomach. Using this technique, they had excellent procedural success in 13 patients. Mean survival was 5.23 months, and 4 minor complications were encountered. In 2007, Lukovic et al. Created a biosynthetic model from the GI tract of pigs in order to demonstrate the creation of a gastrojejunal anastomosis using magnets. The technique involved endoscopic deployment of the magnets under fluoroscopic guidance with the help of a guide wire. The results revealed a technically successful procedure, and the time of procedure decreased from 40 minutes to 20 minutes with practice, thereby demonstrating that this is in fact a short procedure as well, and that this biosynthetic model could be used for training for the creation of such an anastomosis. In 2011, Meyer et al. Created a gastrojejunal anastomosis using magnets in a porcine model with an interesting technique. What was interesting about their technique is that they used a purely endoscopic technique for deployment of internal magnets, but then used larger external magnets to manipulate the endoscopically placed internal magnets. Essentially, the external magnets were used to attract the internal magnets to the anterior abdominal wall, drawing the bowel with them, and then they were manipulated externally to move the two lumens closer together while avoiding other intra-abdominal organs. In this study, again, we are demonstrating shorter procedure times, around 34 minutes per procedure. We're also demonstrating technical success and anastomosis creation in 6 out of 7 of the pigs. Complications included failure to form an anastomosis in 1 pig because the magnets were too large to pass the pylorus. And this is something important to note, that one major limitation of magnets is size. The magnets may be too large to pass through up the pylorus, they may be too large to pass through an obstructed area, and they may be too large to pass through the upper esophageal sphincter. And we will talk about this a little more shortly. Another complication that was seen was constipation in one pig with the endoscopic finding of the magnets adhered to the anastomosis. Microscopically, looking at the anastomotic sites, the granulation and fibrous connective tissue showed no evidence of infection or leakage. In addition to the concern that magnets are too large for certain areas, there was also concern that magnets are too small for the creation of a proper size of anastomosis. In order to combat this, some researchers came up with the idea of using magnets with stents. This is what Van Hooft et al. Did when they performed their study creating gastroenteric anastomoses in human models. 18 patients with malignant gastric outlet obstruction were included. The team used a Cook magnetic anastomosis device, where they placed the magnets and then 8 to 10 days later deployed a yo-yo stent, seen here on the right, into the site of the anastomosis in order to attempt to have a stable and larger size of anastomosis. Unfortunately, this study needed to be terminated early due to adverse events, including 3 stent migrations and 1 stent perforation that led to the death of a patient. The adverse events in this study seem to be related to the stent usage rather than the use of a magnetic anastomosis. However, this did lead to concerns about this overall technique. In another effort to avoid the limitations of magnets, the self-assembling magnet was created. The main advantage of self-assembling magnets is that they overcome the limitations of size that are traditionally associated with magnet use. Additionally, with technological advancement, some of these magnets have been created in such a way that they offer an option for immediate anastomosis creation within the lumen of the magnets. In 2011, Ryu et al. Created the self-assembling magnets for endoscopy, or SAMSON. These were used to create a gastro-jejunal anastomosis in a pig study. The technique involved an endoscopy where a gastrotomy was created to enter the peritoneum and then create an enterotomy. An overtube was advanced into the small bowel to deploy the first magnetic assembly, and the reciprocal magnetic assembly was deployed in the stomach. These systems were mated under fluoroscopic and endoscopic guidance, with procedural success in all 5 pigs and successful anastomosis creation, with no leaks on contrast evaluation. The authors subsequently began referring to the system as the incisionless anastomosis system, or IAS. In 2015, Ryu et al. Used this system to create jejunal-colonic anastomoses in pig studies. Here you can see on the right-hand side how this magnet is miniature and linear within the endoscope and then creates a larger caliber shape once deployed. The technique involved performing a simultaneous enteroscopy to deliver magnets to the small bowel and colonoscopy to deliver magnets to the colon. The magnets were deployed and then manipulated using magnet-tipped catheters. They were mated under fluoroscopic guidance, after which the pigs underwent endoscopy every 3 to 6 days for further evaluation. The procedure time was around 14.7 minutes, which is quite short, and this led to the creation of patent leak-free anastomoses by day 4, which remained patent 3 months at a mean diameter of 3.5 centimeters. The magnets were expelled in the stool by day 12, and there were no adhesions at necropsy. There was full reepithelialization across the anastomosis without fibrosis or inflammation noted. Using the results of multiple prior studies and multiple iterations of the IAS system, the authors performed a 1-year human pilot study, which was very interesting and created a partial jejunal diversion by creating a jejunal-ileal anastomosis. The anastomosis was found to be patent after 1 year, with significant reduction in postprandial insulin, glucose levels, and total body weight in those patients. Another self-assembling magnet called magnamosis has been developed simultaneously. This device is a self-assembling hollow magnet with a convex concave design to the reciprocal magnets, as you can see here in the picture. There have been multiple consecutive iterations published from magnamosis 1 to 4 that I will discuss briefly. Over the course of development of the magnamosis devices, some distinguishing features including the use of gradient force rather than a uniform force, which they have found creates a stronger anastomosis with earlier patency. Additionally, their magnets were developed to only generate enough force to cause necrosis at a distant equivalent to the thickness of 2 compressed bowel walls, thereby avoiding entrapped viscera. In 2009, the magnamosis device was first tested as a self-orienting device made of 2 magnets with 2 different topologies, a uniform compression topology and a gradient compression topology. This was a porcine study, and the technique involved creating a laparotomy with magnetic side-to-side anastomosis. Each of the pigs also had a stapled and a hand-sutured anastomosis for comparison. The study showed that there were patent anastomoses in all pigs with no leak, and mechanical integrity was not statistically significantly different from staple or suture techniques. In fact, there was a trend toward greater strength with the magnetic anastomoses. Additionally, gradient device trended toward greater strength and earlier patency at 1 week, and there was no evidence of stenosis overall. The second iteration of magnamosis, magnamosis 2, was also used to create gastro-jejunostomy and jejunal in pig study. The magnets involved 2 convex concave radially symmetric halves that magnetically self-aligned with radial topography of the mating surfaces. The study was successful, and gastrojejunostomy was patent by contrast fluoroscopy and well healed by histologic exam with excellent burst strength. In the third iteration of magnamosis, or magnamosis 3, the magnet was redesigned to facilitate endoscopic delivery. The magnetic ring casing was modified such that there was a groove lining the outside of the magnet to allow manipulation using an endoscopic snare. They performed this study in 8 pigs, and the technique involved a minimally invasive endoscopic approach with laparoscopic assistance. The study was successful, and all pigs had widely patent anastomoses with complete healing on histology. And after multiple iterations, the first in human series was performed by Graves et al. In 2017. They created end-to-end small bowel anastomoses in 5 patients who were post-open urinary reconstruction. The study design was a prospective single-center first-in-human pilot trial. In this study, the magnets were placed at opposite ends of small bowel to restore continuity after surgery, and the authors demonstrated success with no complication of leak, bleeding, or stricture at 13-month follow-up. This summary table from a 2021 study from our research group by Marash et al. Looks at all studies of magnetic gastroenteric anastomosis creation. As you can see here, the size of the anastomosis has ranged anywhere from 12 to 35 millimeters, and the days until anastomosis creation has ranged from 3 to 10 days, owing to developments improving the size and the duration of anastomosis creation. One additional thing I would like to note is despite the fact that this has been studied for more than 20 years now, there has been only a handful of inhuman studies, with a small number of patients. The uptake of this technique may have been limited by concerns about the duration to anastomosis creation, and also by the concomitant development of alternate minimally invasive techniques for anastomosis creation. Magnetic gastroenteric anastomoses have been limited by several things, including the risk for entrapment of tissue between the magnets, the requirement for laparoscopic assistance, size limitations, and longer duration to anastomosis creation. However, there are many benefits, including the fact that this can be an alternative to surgery in complex patients with comorbidities, and has no retention of foreign material and a shorter procedural duration. Given these known benefits, many solutions have been suggested to address the concerns and continue to be in development to allow for future clinical applicability and uptake of the magnetic gastrojejunal anastomosis. Thank you very much for listening.